The big advances started with the combination of chemoimmunotherapy, the FCR regimen by Michael Keating at MD Anderson in early 2000s, and that really improved the responses, the complete remission rates. Then the second thing that really happened in the late 2000s was the understanding that the B-cell receptor pathway plays a major role. The constitutive expression of that B-cell receptor pathway leads to the patient's disease progressing, and once that became known, then targeted therapies could be developed. So I've got a slide that classifies from the 1970s, where we had chlorambucil and single therapies, lymphoma type regimens, fludarabine and the purine analogs in the late 1980s and 1990s, combination therapy, and really the 2010s have become the era of the targeted therapies. So what is the status of disease now? Well, really, it's depending on every individual patient understanding their specific disease. The mutational status is playing a major role. That 20, 30, 40%, even more percent of the patients who were treated with FCR and had the mutated subtype immunoglobulin genes and favorable cytogenetics at 13-year follow-up are still without any evidence of disease. And so MRD status is playing a role there, but the important thing is that potentially chemotherapy, chemoimmunotherapy can cure some patients.